Okay, welcome to Deuk Spine Institute. We are performing the Deuk plasma rhizotomy procedure, which was developed and pioneered here at Deuk Spine Institute. This patient has pain in his back, specifically in his facet joints, and we've just completed his Deuk laser disc repair for the disc pain. Now we're going to go fix his facet pain. Most doctors only know how to do a radiofrequency ablation, pain management doctors that is, to treat facet pain. However, the problem with RFA is that it doesn't last. If it works, it doesn't last. So patients that have it done, they basically have to have it redone every 6 months or sooner. And we pioneered a new technology here at Deuk Spine where we can actually permanently get rid of facet pain. And that's what we're going to do today. So we know this patient, has facet pain and shot. Our goal here is to treat it permanently for him. All right, so I'm trying to get to L3, and right there, I feel like that should be the right spot. Shot. That's perfect. Yeah, so we're gonna start by, and what we're doing is destroying the pain nerve to L3. Okay, L3, L4, L4, L5, L5-S1. Shot. One down. Shot. Next we're going to move to L4. And that's pretty much a good spot. Right about there. Now what allows us to do this procedure is several things. We have technology. The technology we're using is very sophisticated, state-of-the-art technology. Specifically, we have literally the best fluoro machine. That's exactly the perfect spot. You guys see where that is?
Yes, we do.
Yeah, his muscles are jumping a little bit, but I think we're okay. But the best fluoro machine in the world we're using that's commercially available. I don't have access to experimental machines, but this is the Siemens fluoro. Yeah, and this is truly the best in my opinion. It gives you the very best performance, the best pictures, so you can see exactly where everything is. Yeah, Berndes, I don't know what you can do to help me out. Every time he's tightening up, it's moving me. I think, and he does have, I think, an issue with bone metabolism. Shot. Yeah. So I need to be a little bit more medial. All right, that's 2 down. Shot. All right, there's L5. You can see it there. Wow. Interesting shot. His bone is soft, very soft. Usually an indication of osteoporosis. He's going to need to be really careful. Yeah, no, it's good. Thank you. Almost done with this side. It's making it much better, Dr. Berndes. Thank you. Let's see where that is, shot. The thing about this procedure is you have to also be able to feel that you're on the bone, right where you need to be. I think it is better, Luis. Mm-hmm. And the problem is patients with metabolic bone disease like osteoporosis or osteopenia, their bone is so soft. Huh. Can you scrape that?
Yes, sir.
It's just catching. Uh-huh. There we go. Shot. All right. Almost done with this side. Shot. A little bit lower than I want to be. Shot. That right there is like literally the most perfect spot. You guys see that? Henry, you still there?
Yes, I am. I apologize. Monica asked me a question.
Is that Monica again? That Monica?
She was just asking how far we are.
You got to watch out for her.
No, no
She
problem.
will mess you up.
Yeah. If there was a question of asking if there were any questions, we do have one. If we have a moment to
I'm happy to answer it.
no
Yeah.
problem. This comes from Kieran once more on YouTube.
All right, that guy's on fire.
Yes, he is. Asking, would you
Shot.
suggest an endoscopic laminectomy and excision of a large L1 to S1 hernia?
No, I would not. This guy's funny. Why would you ever do a laminectomy? Why would you ever want to do a laminectomy? Karen? Well, Karen knows better. He knows. He's been watching our surgeries. We've been talking about how bad laminectomy is. Shame on Karen. Pull back then, inject. No, I would never recommend a laminectomy for a herniated disc. You don't need a laminectomy. Laminectomy is old style. Okay? I would recommend a laminectomy for a herniated disc, and the same time that I recommend a frontal lobotomy for what? Or a bottle in front of me. A frontal lobotomy, there's no reason to do a frontal lobotomy. It's an old procedure that is totally unnecessary. And there's no reason to do a laminectomy. It's an old procedure that is totally unnecessary. Yeah, he's jumping again. But we need about 3 minutes, maybe 3 to 5 minutes max. Shot. Yeah, Kieran, I'm sorry. I'm not sure if you are just joking around or if I should take you serious. Tell me when. Yeah, Kieran, laminectomy is a surgery that we've been doing for 100 years. It's unnecessary, it's destructive, it's damaging, it's destabilizing, it's bloody, it's scarring, it's painful, it's completely useless garbage. Let me ask you a question, Kieran. Are you trying to remove the lamina or are you trying to remove the herniation? Because the lamina is not the herniation. So the reason why surgeons do the laminectomy is to get to the herniation, right? But what if you had a better way to get to the herniation? Endoscopically, transforaminally. That's what we do. Okay, there's no reason, there's no reason to do a laminectomy unless you don't know how to do endoscopic surgery. And if you don't know how to do endoscopic surgery, maybe you shouldn't be doing surgery. Maybe you should just be doing something else like gardening or hospital administrator.
Kieran had a comment. They said, of course, I know I would not suggest that, but I was thinking if there was a large hernia.
No, you don't need to do a laminectomy. You never need to do a laminectomy unless you don't know how to do endoscopic surgery. Then you need to do a laminectomy. Shot? Yeah, I would not recommend laminectomy to any patient. All right, that's done. Shot? That's perfect. And now for two more, and we'll be done. This will be L5 left. Shot. Got my finger in there, Jordan. If I get bone cancer from you, I'm coming to live with you. You're going to take care of me. You know, I once had a PA named Augusto, and Augusto and I would have these talk about our experiences. And he told me about Argentina, where he practiced orthopedic surgery. And boy, they do things different there. But he would tell me that a lot of times they didn't have lead for their surgeries. And they would just do the surgery without lead, even though they're using an x-ray machine. So they would basically radiate themselves as doctors. That's beautiful. No more muscle spasms. Whatever you gave them. What did you give them? What do you think it is? Propofol or fentanyl? Shot?
Combo.
Huh.
One's
Oh.
analgesic, one's anesthetic.
I would love to try one first and then see, you know? Shot. So this procedure does require a little what we call poking around. And what it really means is navigation. I'm trying to navigate to the area where the pain nerve is. Shot. And to do that, I have to, you know, move the wand around a little bit. And that's what I'm doing. Okay. Well, that should be everything but one left. That last one will be the, what do they call it? L5 dorsal ramus, right? Okay. Shot. And that's going to be a little too low. Shot. That's too low. Shot. That's perfect. L5 dorsal ramus. All right, let's see. Shot. Again, soft bone. Very soft bone, I think. All right, we're done. Great job, everyone. Any questions?
We just have one question.
Sure.
This comes from Wilhelm on YouTube.
Well, let's take a look. So remember, we already did the laser surgery, everybody. And that's the laser surgery incision right there. Okay? And now we just did the Deuk plasma rhizotomy. Let me have a tape measure. Take a look at this, folks. Look how small this is. Literally. All right, 5 millimeters, half a centimeter, okay? Yes, I'll take the question.
Question from Wilhelm asking, when you were saying the bone cancer you just had, that in your words, you weren't really saying that's what you were that you are seeing right there. Just
No, Wilhelm, what I'm saying is bone cancer, no, not in this patient. I was making a joke with my staff. basically bone cancer like osteosarcoma, myosarcoma, leiomyosarcoma. These types of sarcomas, bone cancers, come from excessive radiation. And so we want to minimize the amount of radiation our patients get and the staff get, including me. So to do that, you have to have good x-ray machine. Good. Because if you have the best x-ray machine, you're going to take a shot, you're going to deliver a dose of radiation, you're going to see what you need to see, and you're not going to radiate anymore. Now, if you have a really bad quality x-ray machine, then you're not going to really see what you need to see. You're going to have to take another radiation shot, and then another one, another one, another one. So if you look at the amount of radiation time you have with a poor quality machine like most doctors have, it's going to be like 3 minutes. But if you look at our radiation time, it's around 30 seconds to 45 seconds. So why do we have so little radiation? Because we have a better machine. Other doctors don't spend the money to buy these machines. This is a $165,000 machine. So they want to buy the machine for $70,000 or $80,000 so they can not spend as much money. We buy the best, and because of that, we have good quality. So I was joking with Jordan that if he keeps taking pictures with the x-ray and gets my hand in there, I'm going to get bone cancer. But the truth is that we have the safest machines available. I hope that explains it. Blood loss, 2 mils. Thanks everybody for joining us. Go ahead and show the video on how the Deuk plasma rhizotomy works, and we'll wrap it up.
Copy that.